Good morning, Fairlawn Volunteer Ambulance Corps. My name is Jonathan Barr, and I'm happy to be presenting to you today the very first episode, and what is hopefully the first of many in a new FLVAC training series. And this one will be the first episode on vital signs. Some of you might also be wondering what MedicineWithout is. For the time being, while we're figuring out the best platform to host this, that's my own EMS website and blog. And so you're be able to find this presentation and other EMS related articles that I've put together on there for your education. And so some of you may know me, may remember me from my time in the ambulance corps, but some of you might not. So for those of you who don't know me, I actually started out as a cadet at 16 years old on the Fairlawn Volunteer Ambulance Corps. I continued my EMS career in college, serving as training officer and director of operations of Cornell University EMS. Later went on to attend medical school and eventually residency in emergency medicine at the University of Pennsylvania, where I continued my involvement in the EMS and disaster world. Here I was part of the hospital emergency response team and was one of the only resident physicians who was trained to respond to highly infectious organisms. This is my Ebola suit, for example, and seaburn events. And that training came in handy because we ended up dealing with a highly infectious organism called COVID-19. And I was actually one of the residents involved in the incident command center and helping to establish the field tents outside of the hospital. And this is actually my incident command suite. And I point this out because a lot of these skills that I used to do this, I developed right there in the ambulance corps with Dave Epstein and Brian Lubroth practicing at the 4th of July and the fireworks and the parade on Memorial Day. So all that stuff, all the things you're doing right now in the ambulance corps are really important for whatever you're going to do going down the road. Later on, I moved on to fellowship in EMS, and my role in ever more complicated incidents has kind of grown. This was an example of a field hospital we created for Afghan evacuees in the setting of that recent evacuation from Afghanistan. And so now you can find me at Cooper University Hospital. I work as an ER doctor there as well as an EMS physician. I do both air EMS out on the helicopter as well as ground responding on the streets of Camden. And this is in my fellowship, so it's my very last and final year of training after many years of kind of being in training. And next year I'll be an assistant professor of emergency medicine at the University of Pennsylvania and working from there. And so I hope to you in that role to be able to bring you lots of good training and educational materials to help you all get better. So since this presentation is posted online, I just need to put this disclaimer up there. You can take a moment to read it. Also, as is tradition in academic presentations, I don't have any financial conflicts of interest to disclose about the topic I'm talking about today. So I don't have any interest in BP cuffs or other vital sign monitoring machines or anything that would sway my opinion or teaching on the subject. And so let's go over what we're going to get into today. So we're going to talk about what vital signs are, when and how to get them, what the common vital signs are and how to interpret them as well. And then at the end, this presentation in the beginning is going to be geared towards cadets and probationers, but I want someone to be able to get a little bit of something out of this. So I have some more advanced topics in vital signs at the end. So if you're new, you can kind of skip over that section. But if you know, hey, you're like, I kind of mastered this, I want the next steps. These are some next things you can do to really kind of up your skills in how you handle vital signs. And at the end, we'll go over some cases and how to interpret some key vital sign patterns. So first of all, when we talk about vital signs, what do we mean? What are we talking about? So vital signs are essentially a diagnostic test. They're no different than the lab tests I send in the ER or a chest x-ray. They're actually a diagnostic test. So when you take vitals on a patient, that's the first step in diagnosing what's going on with them. Now I know a lot of times EMTs are told, hey, you're not diagnosing. That's true in a sense, but you are performing diagnostics, which will inform later diagnosis when someone like myself sees the patient. The other thing I want to say and make explicitly clear is there's a reason vital signs are called vital signs. They are vital. I'm going to say that again. Vital signs are vital. This is your first clue in that old kind of EMS axiom of air goes in and out, blood goes round and round, any deviation is a problem. Vital signs are going to be your first clue that there's a problem with air going in and out or there's a problem with blood going round and round. So you must get them on every patient. I'm going to say that again. You must get vital signs on every patient. It doesn't matter if it's a refusal. It doesn't matter if it's a lift assist. It doesn't matter what it is. You should be getting vital signs on every single patient. And if the patient's refusing to have their vital signs taken, you should explain to them the risks and benefits of that, saying, hey, vital signs are really important. They tell us how your body is working. They can clue us in to abnormalities in your body. And some of those could be life-threatening and serious. Are you sure you don't want us to take them? Because you should really stress vital signs are critical to get on every single patient. So you should aim for 100% of your patients getting at least one set of vitals. Because vital signs are so important, it's critical that every abnormal vital sign is addressed. You have to address every single one, even if it's slightly abnormal. To give you an example of what I mean, you might find someone with a blood pressure of 150/90. Now that's an abnormally high blood pressure. Now, depending on the clinical situation, if the patient otherwise feels fine, you might not need to do anything in the emergent, immediate setting for that high blood pressure. But what you should not do is say, hey, yeah, it looks okay. What you should do is you say, hey, your blood pressure is a little high. I want you to follow up with your regular doctor. In another circumstance, you might find a vital sign is abnormal and find that you need to treat it right then and there, either through BLS or ALS interventions. So every vital sign, you either should be treating it if it's abnormal, or at a minimum, if you're not treating it, you need to disclose it to the patient and explain to them the possible risks. So I want to really emphasize any abnormal vital sign, you must address it in some way, even if that is as simple as disclosing and educating the patient about it. This is a big one. I can remember times when I was an EMT in the back of the Fairlawn rig and ALS was pressuring me to get a vital sign. I was having a hard time getting it. And at one point I said, hey, I can't get it. I don't know. And the medic got a little mad at me and he's like, well, you have to get it. You need to get me something. And I tried again. Eventually I was able to get it. But the lesson there is no matter who is pressuring you to obtain anything, never make up a vital sign. And I'll give you an example about how dangerous this is. Like if you're getting pressure to get a blood pressure and you just make up a number, let's say they then give that patient nitroglycerin for chest pain and it lowers their blood pressure. Well, if you started out too low, you might drop it further and the patient could die from it. So it's really important to have accurate vital signs, and it's really important that if you're having a hard time obtaining the vital sign, just say so. And sometimes the vital sign is hard to obtain because it's really low. Sometimes the hardest, if you're having a hard time hearing the blood pressure, it might be because that blood pressure is super low. And that in itself should give you a clue that this patient is quite sick. So again, never, ever make up vitals. It's okay to say you don't know, and people should accept when you say you don't know, they should be okay. They should understand you're not making it up, and it's really critical. I want to emphasize this over and over again. Never make up a vital sign. The other thing you need to understand about vital signs is remember that vital signs are like a snapshot in time. What you need to see is what's happening to the vital signs over time, right? So sometimes people say, oh, vitals are stable. Well, you can only say they're stable if you have at least more than one set to say that they're not changing, okay? But the vital sign trend is really important. So remember, when you take someone's vitals, you're seeing what their body is doing at that moment in time. That doesn't necessarily tell you if they're going to get better or if they're going to get worse. So you have to remember that they're just a snapshot. The other thing you have to remember is that vital signs are one piece of the clinical picture, right? You have to, take your history. What's the history of present illness? What does the rest of your physical exam show? What do the vital signs show? Do my vital signs make sense for what I'm seeing, right? If I got a blood pressure of 20/10 and the patient's awake and talking to me, we know that doesn't make any sense, right? It doesn't fit with the clinical picture. Now, that might be a particularly extreme example, but I hope you understand the point that vital signs need to be interpreted in the context of the patient you're seeing, right? Okay, so it's one piece of the puzzle, but it is a critical piece of the puzzle. So we talked about kind of what vital signs are, what they do, when should you get them? So I think I said this before, and I put it in here again, you should get them on every single patient, every single patient. Now you might be saying, okay, well, tell me a little bit more. When actually in the patient encounter should I get them? So when you encounter a patient in the pre-hospital setting, you're going to start with their scene size up. Remember, those are things like check the scene for safety, number of patients, mechanism of injury, nature of illness, consider C-spine, consider additional resources, right? Those are the things you're doing as you're sizing up the scene. Then you're going to do your primary survey, right? Remember, our primary survey identifies immediate threats to life. So this is typically, our ABCs, airway, breathing, circulation. Sometimes people, I like to use the acronym XABCs, where X stands for exsanguinating hemorrhage, airway, breathing, circulation, D, disability. Sometimes I also remember D for diesel. Is it time to go? Should we load and go? So remember, that's your primary survey. You're identifying immediate threats to life. Now, I told you vital signs are critically important. They help you identify threats to life. So when you're on a scene, you're going to get your vital signs somewhere between the end of your primary survey and as you're starting the secondary survey. And the secondary survey is your more detailed exam that you're doing on scene, right? Or in the back of the ambulance. You might be loading and going already because you have threats to the primary survey, right? Now, a full discussion of the primary and secondary survey, we could do that in another lecture. The point I'm trying to emphasize here is vital signs you should try to obtain them fairly early in the process, right? Right at the end of your primary survey, once you've done a quick pulse check, quick airway check, quick breath sound check, you should be starting to get vital signs. If you have two people, which you always should, someone can be doing the survey while someone's working on vitals, so you can get that fairly quickly, because if the patient has unstable vitals, that might be time to load and go, right? And so remember, you're trying to get them fairly early in the process, right after the scene size up, kind of near the tail end of your primary survey, or at some point between there and your secondary survey, okay? Now, I also put an arrow towards the secondary survey because you're later going to repeat vitals as you go forward, and so you're definitely going to get another set during your secondary survey if you've had enough time with the patient to do so. So you might be wondering, okay, well, how much time should I wait until I repeat them? So if the patient's unstable, you should be doing this every 5 minutes or sooner. For a stable patient, every 15 minutes is acceptable, okay? Now, let's talk about the common vital signs and how to get and interpret them. So these are, when people say, hey, get a set of vitals, they're most commonly referring to heart rate, respiratory rate, and blood pressure. Some people also include in this list temperature and pulse oximetry. I include that when I'm in the hospital and when I'm in the field as part of like an ALS unit. That being said, I'm not really going to speak that much about temperature and pulse ox because not all BLS agencies have it, and they're a little bit, they're kind of outside the scope of what we're going to talk about today. So we're going to focus on heart rate, respiratory rate, and blood pressure. I want to give a fair warning before I get into these vital signs. The vital signs I'm going to talk about today pertain to adults, okay? We could do a whole nother lecture on pediatric vital signs in the future if you guys are interested in that. But for right now, we're going to focus on care of the adult patient and adult vital signs. So let's start with heart rate. How are you going to get it? So heart rate is most easily calculated by feeling for a pulse, right? And our most common site in most people is going to be the radial artery in the wrist. But you can also feel it at the carotid artery or the femoral artery. Those are good places in adults. Now, there are other places you could feel the pulse, but in the EMS setting, those are probably the most common, at least when you're trying to calculate the heart rate. You might also be feeling distal pulses in the feet when they have an injury, an extremity injury. But for the purposes of obtaining vitals, I recommend you count a radial or a central pulse, either a carotid or femoral. And I do want to give you a little tip about when you do it. So you can feel for a pulse with any finger except the thumb. And I often will put 4 fingers down on the wrist to give me the biggest area of finding it. And you're going to do it, let me try to get that in the camera a little bit better there. You're going to do it on the thumb side, which is the radial side, not on this side. The thumb side, right, is the side where you're going to do it. Okay, and you're going to press against there and you're going to feel the pulsations. And you're going to count the pulsations for how many are in a minute. Now, you could count for a full minute, but that takes a long time. So I count for 30 seconds and multiply by 2. There are some people who count for 15 seconds and multiply by 4. That's a little bit less accurate, so I recommend counting at least 30 seconds when you do this. Now, what is the normal range? So for an adult, the normal range of heart rate is 60 to 100 beats per minute. So anything outside those ranges, remember, needs to be addressed in one way or another, okay? Now, what about respiratory rate? So respiratory rate is the number of breaths you're taking in a minute. So that can be counted by visual. You can watch the patient's chest rise, right? You can see it go up and down, and you can count each inspiration, and you can do that for 30 seconds and multiply by 2. That's how I recommend you do it. You can also count for the full minute. Now, sometimes I feel like it's hard to physically see the respirations, and so what I will often do is put a hand on the shoulder and feel the breaths, okay? So that's one thing you can do. Now, sometimes what I'll do is I'll have one hand on the shoulder, one hand on the wrist, and I check my heart rate and respiratory rate at the same time. Or what I'll do is I'll count one for 30 seconds and I'll count the other for 30 seconds. That way the patient doesn't know which one I'm checking in that particular moment. and then I get both my vital signs that way. So that's one method by you could do it, is have one hand on the wrist, one on the shoulder, and then do your heart rate and respiratory rate just like that. Now, for an adult, what is the normal respiratory rate? 12 and 20 is considered normal. Most of us who are not in any distress are going to be closer between 12 and 16, but 12 and 20 is the acceptable range. Anywhere outside that, you need to be figuring out why is that the case. Okay, you need to have a discussion. You need to address that vital in some way. Now, blood pressure. So blood pressure, at least the way we check the blood pressure, is by using a cuff and inflating it, usually on the arm, although there are methods to do it on the wrist, on the leg, and things like that. This, I think, is best learned by practicing it on each other and practicing it. And I know that your training instructors can show you this in person. Your experienced EMTs there can show you how to do this. It can be done by listening. That's called by auscultation, and that'll give you a systolic and a diastolic blood pressure. It can also be done by palpation, which will give you a systolic blood pressure only. I'm going to defer further discussion of the techniques to in-person training because I think it won't come through as well over the video. So practice that at headquarters, but I am going to tell you a little bit about what's normal and how to interpret it. I do also want to tell you a little bit of pitfalls, pearls and pitfalls. So you might be tempted when you're looking at the blood pressure cuff, the meter, you might be tempted to look at the needle rather than listen. Don't do that. You really want to listen and hear it. The sounds are what determine the blood pressure, not what you see, okay? Now, the other thing you want to watch out for is the cuff too large or too small for my patient? So you really want to make sure you've measured that out appropriately, and you can, I recommend working on the sizing when you practice it in person. Just know that if you use a cuff that's too big, the blood pressure will be artificially low. And if you use a cuff that's too small, it's going to appear artificially high. Now, the other thing that I see people try to do sometimes is they try to measure the blood pressure over clothing. Now, the problem is clothing adds extra thickness, which is affecting the arm circumference, which is part of the way how blood pressure is measured. So you will not get as accurate a reading if you do that. So if you really need accurate blood pressure, you should not do it over any clothing. You should remove their arm out of the sleeve or roll the sleeve up or whatever you need to do to get the blood pressure cuff over just their bare arm, okay? The other common mistake I see is not measuring at the level of the heart. So you remember, if you want blood pressure to be accurate, you really should try to measure at the level of heart to the extent that that's possible. Now, sometimes patients supine or whatever, and the practical considerations outweigh the accuracy there. But if you want the most accurate possible, you really should try to measure at the level of the heart. That's done best when the patient's, by the way, sitting upright. That's not always possible in an EMS setting, and I am well aware of that. But if you want to know the perfect, ideal way to do it, you'd like to have them sitting upright. You're supporting their arm, and you're holding it at the level of their heart, kind of like that. Okay, so you're holding it, and you're supporting it. So I will often tuck my arm under theirs and use that to pump while I put my stethoscope with the other hand. So you can practice those techniques, but I just want to point out some of these pitfalls. Now, the normal value for blood pressure, so you might see some different numbers out there for different things. Generally accepted is 120 over 80. Now, you have to understand how this value was interpreted, how this value was determined. So when they were trying to figure out, like, what is the normal human blood pressure, they took a bunch of 20-year-old adult healthy males and they measured the blood pressure, and this is what they came up with. But as you know, not everyone is a 20-year-old adult healthy male, right? So females might be a little different. Other people might be different. But I think that having this number in your head is a good ballpark to reference, like, hey, it should be approximately 120 over 80. If I'm far off from that, there's potentially a problem. I need to address that vital sign in some way or another. Okay? And blood pressure is measured in millimeters of mercury. That's the pressure measurement. So let's talk about what blood pressure means, okay, when you're taking it. So the top number is the systolic blood pressure. That's referring to the pressure exerted against the artery walls during systole. Systole is where the heart is pumping. So that's where the heart is squeezing. So it's reflecting the pressure when the heart is pumping there. Okay, that's really important that you understand that. That's the pressure against the artery walls as the heart is squeezing, right? By contrast, diastole is the pressure that remains when the heart's in its relaxation or filling phase, which is called diastole, okay? So this is an important point. I think everyone likes to focus on the systolic blood pressure when the heart's pumping, but the diastolic blood pressure is equally important because it's telling you about the degree of vascular tone. It tells you about the degree of vasoplegia, What does that mean? What is vascular tone? What is vasoplegia? That is how big or small the blood vessel is. So is the blood vessel constricted and there's high vascular tone, or is it wide open and too big and there's low vascular tone? And this has clinical implications, and I'm going to explain that in a little bit. So just remember that diastolic blood pressure best gives you an estimate or measure of the degree of vascular tone in the patient. Now, for those of you who are cadets or probies and who are just learning this, I suggest you pause here, master everything I've talked about up until this point, master the techniques of obtaining vital signs in your practical sessions, and then come back to this, okay? Now, for those of you who are general members or who are a little more advanced, or you're like, you know, I got the basics, John, let me learn something a little more advanced. That's what we're going to do now. So I want to give you guys a couple advanced things that you can do. So one more advanced vital sign interpretation is to look at something called the pulse pressure. Pulse pressure is calculated pretty simply. It's a systolic blood pressure minus the diastolic blood pressure. The normal pulse pressure should be somewhere between 40 and 60, right? If you think about your normal blood pressure of 120 over 80, the difference is 40. It's easy to remember that way, okay? Now, I don't recommend that anyone in the EMS setting, including myself, does any math. So do this on a calculator on your phone, or you can pull up, there's plenty of apps that'll calculate this for you. I happen to like MD Calc. I don't have any sponsorship. I'm not paid by MD Calc in any way. That's what I personally use because I like it. So I don't have any conflict of interest with that, but use some kind of app or some kind of calculator to do this. Don't do math in your head on scene, okay? Now, why is it important? And it's not actually important as the actual number. It's really just important, is it narrow or wide? So is it too low or too high? So remember that narrow pulse pressure can tell you that you might be going into hemorrhagic or hypervolemic shock. You might be getting those blood vessels to constrict, and that happens as the systolic, remember, narrowed pulse pressure means the systolic and diastolic blood pressure are getting closer together. So why does that happen when you're bleeding out? It happens because the vascular tone, remember I said, corresponds to diastole, vascular tone, gets higher. So diastolic blood pressure coming up, and your heart doesn't have as much pump around, so systolic blood pressure coming down. So when you see the systolic and diastolic blood pressure getting closer to each other, that's called a narrow pulse pressure, and that can tell you that you should be worried, hey, I think there might be hypovolemic or maybe hemorrhagic shock developing, okay? So narrow pulse pressure can be a clue to that. By contrast, widened pulse pressure, meaning the systolic and diastolic blood pressure are getting further away from each other, can happen when there is vasoplegia or increased vasal tone. So if the diastolic blood pressure starts dropping, particularly if it's dropping to less than 40, so if you have a diastolic blood pressure less than 40, you should start to worry that you might be getting a wide pulse pressure and the patient could be getting vasoplegic. Now, what conditions cause vasoplegia? A lot of them, but the one that kills the most people nowadays is septic shock. So septic shock, or which is the worst form of sepsis, can lead to dilated blood vessels, which drop the blood pressure, and usually you'll see a widened pulse pressure in this setting. You know, and not everything's perfect, but if you want to get a clue, if you see a wide pulse pressure, you should think that there's some process dilating the blood vessels. Now, there are other forms of distributive shock where you might see that, okay? But I tend to think of this most commonly in our population in terms of what's dangerous and what people die from. If I see the pulse pressure widening, I start to get worried. Are they getting septic? Are they getting vasoplegic for something, okay? So something to think about. And remember, I told you vital signs are just one piece of the puzzle. You have to take everything in clinical context, right? If you see a widened pulse pressure in someone who's febrile to 103, tachycardic, they're coughing up a storm, you might be able to say, hey, maybe they got pneumonia and they're getting septic, okay? So something to think about there. Now, the next vital sign parameter that you can think about is called the MAP, which stands for mean arterial pressure. This is how you calculate it. Again, I don't memorize it. I just calculate it on my app, but it's important to understand conceptually what it is. The mean arterial pressure is the pressure that the organs see. That's like, it's not exactly an average, but you could think of it kind of like an average pressure that they see. Remember, it's not exactly that. Look at the formula there. You'll see there's different weighting. But that's the pressure your organs see, and that's the pressure that your organs are using to perfuse with. And in general, we're targeting a MAP of 65 usually. Now, in different conditions, we'll target different MAPs, but 65 is a good ballpark number to have in your head. Less than 60 to me is worrisome. That if the MAP is less than 60, I'm worried that that patient is not perfusing and they're very sick and they need either fluids or pressors or something else, okay? So this can be a clue to you. So why would you need to know this as a BLS? This is a clue to you that my patient is critically ill and needs ALS or fast ride to the hospital. If you see their MAP is low, you should get worried if they have a low MAP, okay? So this kind of reiterates what I said. MAP greater than 60 is what you need for adequate tissue perfusion. In patients with septic or septic shock, you're trying to go for 65, okay? Now, if we're looking at the patient in shock, there are other vital sign parameters we can calculate. So one of them might be the systolic shock index. So this is just your heart rate over systolic blood pressure. Now, this is an important thing. So the higher it is, the higher degree of shock. But importantly, if it's greater than 0.9, that's associated with increased mortality, aka dying, and key for you to understand, peri-intubation cardiac arrest. So if you get on scene and you check the vitals and you find the shock index is bad and the paramedics are trying to RSI, which they might because they like to do that, you should be like, hey, I'm worried that this patient could get sicker. Have we resuscitated them well enough before RSIing? You know, and some of the ALS units in North Jersey will actually calculate a shock index as part of their RSI protocol and use that to determine the dose of the RSI meds that they'll use. Now, this is a little bit beyond the scope of what we're going to talk about today, but shock index is important to understand. It's especially important in trauma patients who are bleeding, is when I would employ this one the most, okay? So if you have someone who's bleeding out or something, then you would consider calculating this type of shock index. Now, what about the patients who are not bleeding out? What about those septic patients you were talking about, John? Well, then we also have something called the diastolic shock index, which is the heart rate over diastolic blood pressure, right? So if you see a diastolic blood pressure less than 40, or if you see a diastolic shock index greater than 2. Now, how do you calculate diastolic shock index greater than 2? Just remember that means the heart rate's double the diastolic blood pressure, okay? That'll give you greater than 2. So let's say your diastolic blood pressure is 60, but your heart rate's 120. That's a DSI of 2 or higher. You should then be worried that this patient has vasoplegia and shock, and they might need vasopressors. So this means patient is sick, they need paramedics. And the reason I point out these measures to you is you might start to see these vital sign abnormalities before the patient showing other signs. This is like an early warning system. So if you're advanced enough and you can start doing these things, you might pick up on things faster than you might otherwise, okay? So diastolic shock index, heart rate over diastolic blood pressure, right? Just the diastolic version of this. And remember, a diastolic version is telling you about vasoplegia, which is telling you about shock states that involve that, such as septic shock. Cool? So now that we've gone through vitals, and if you're a cadet or probie, feel free to tune back in at this point so that you can kind of review these patterns. Let's look at some patterns of vitals and see what we can learn from them, knowing nothing else the patient. Remember, I told you always interpret the vital signs in clinical context. But let's say you didn't have the context. Let's say patient's unresponsive. They can't tell you anything. There's no bystander. All you have is a set of vital signs. You don't know anything else, right? What might you start to worry about? So if we look at pattern 1, we see that the heart rate is 120. Tachycardic, bradycardic, normal. Tachycardic, right? So heart rate's too high. Now let's look at our blood pressure. Too high, too low? It's too low, right? 120 over 80, think 90 is less than 120, so it's a little bit too low, right? Respiratory rate, 24. Too high or too low? Too high, right? A little bit too high. Pulse pressure. So are those systolic and diastolics coming closer together? Yeah, they are. It's definitely less than 40 difference between them, so it's a narrow pulse pressure. And our MAP here is 81. So is that high enough? Yeah, it is. So when you see tachycardia plus hypotension, right, if you see those two things together, that should make you think shock, okay? That is a shock state. Now, we can't go into all the details of what shock is in this particular presentation, but we can keep that for a future topic if you guys want. So this is now a patient going into shock. Now, what kind of shock? Well, remember, our pulse pressure is narrow. Our systolic and diastolic blood pressure are closer together. So narrow pulse pressure should make me think that the blood vessels are constricting. So that would make me think this is maybe hemorrhagic shock, right? So this is probably like a hypovolemic shock or hemorrhagic shock. Now, that's knowing nothing else. you should be thinking about this. And if you see vitals like this and you don't see any blood anywhere, maybe you need to roll the patient over or look more closely. Maybe there's something you're not seeing, or maybe they're bleeding internally and you can't see it. That's possible too. Or there's something else going on that's clamping down their blood vessels. But that's just, I want to give you one sense of the pattern, that the first most important thing is you should recognize tachycardia and hypotension is a shock state. Then you can try to figure out, why are they in shock? Are they bleeding on the floor? Are they septic? What is going on? And then you can look at the pulse pressure, and that can help you narrow it down a little bit. So let's look at an example 2, right? Heart rate's the same, right? We said that was tachycardic. Blood pressure, low. Look now, though, at the diastolic blood pressure. Diastolic blood pressure less than 40. Interesting, right? Respiratory rate's the same in this case. What about that pulse pressure, though? Now it's widening out. It's different than before. So we have a diastolic blood pressure less than 40, a little bit wider pulse pressure, right? Right? So this could be someone who has, and also I didn't mention it, but look at the map, right? Map's 54 here, right? I'm starting to see this widen out, and it might not be all the way widen out to be totally abnormal in the moment, but this case, less than 40, whenever you see less than 40, that should catch your attention. This now is reflecting someone who probably is having vasoplegia, vasoplegic shock. What kills people with vasoplegic shock? Many things, but the one I worry about is septic shock, right? And you probably see this, this is like your Maple Glen patient who has a bad UTI and is starting to get sick. They could be in septic shock, right? So key things here. Note the difference in the diastolic blood pressure. Note how the pulse pressure here is much closer. Here is a little bit wider. And look how I'm not calculating exactly. I'm just seeing how close or far apart they are to each other, right? And then look at the difference in the map by that, right? So this person might need to get some vasopressors, like norepinephrine or epinephrine, okay? Something your ALS might do. Now let's look at pattern 3. Right? Now we see the heart rate of 40. Is that high or low? It's low, right? We already said that this was high, so this must be low, right? It's less than 60, so it's low. So we have bradycardia. Let's look at our blood pressure now, right? That's pretty high. Really high, right? Now, what about the respiratory rate? So it's 20. Notice how I also noted that in this case it's irregular. That's important for this particular pattern. Okay? If we look at the pulse pressure, it's a little bit wide. Okay, fine. And then the map is actually pretty high here. Right? So that's interesting. So what is going on here? So when you see the constellation of bradycardia, hypertension, and irregular breathing, sometimes called a Cheyne-Stokes breathing pattern, this shouldn't make you worried about Cushing's triad in the setting of a head injury. So if you see a patient with these vitals and they just had a head injury, you should be worried that something is causing the pressure in their brain to get higher, such as blood or swelling. And this patient is at serious risk of herniating and death. So this is a dangerous situation. So if you see this, you should recognize and say, hey, I'm worried this patient has Cushing's. We need to get to a hospital that has neurosurgical capability. Okay? So that's an important thing to do there. Okay? And last but not least, let's look at pattern number 4. So we see a heart rate of 107. Interesting. Okay. So we know that that's a little bit high, right? It's above 100, so it's tachycardic. Let's look at the blood pressure here, 110/80. Yeah, I mean, we said 120/80 should be the ballpark. Remember, that's 20-year-old young, healthy adult male. Like this could be normal for someone, right? This is not bad. This is maybe someone with low normal blood pressure. That's fine. I'm not super worried about this yet. Respiratory rate 20, right? Upper limit of normal. Pulse pressure is a little narrow. It's interesting. Just slightly narrow, not nearly as much as this guy, right, in pattern 1. And the map's 90, so that's okay. So what you're starting to see here, and what I start to be worried about is, I'm seeing the heart rate start to tick up. I'm seeing the blood pressure maybe start to come down. I'm seeing the blood pressure start to narrow. This person might be in compensated shock, and I think my little video might be blocking things. It just says compensated shock here. So this is someone, right? You might say, oh, this person looks fine, I'm going to send him home. But this person is someone who might get worse, right? They have abnormal vitals. Their heart rate is too high. So this needs to be addressed, right? You need to say, hey, your heart rate's too high. I'm worried. Your blood pressure, it might be okay for you, but this is only one snapshot in time. I think we should take it again, or that we should have you monitored in the hospital to make sure it's not getting worse. I'd like to see your heart rate come down and your blood pressure go up a little bit. or what have you, right? So this is someone who could look kind of normal, but is at risk to decompensate because they're still in that compensated phase of shock. And we can talk more about compensated shock in another lecture if you guys would like. It's a little bit beyond the scope of this particular one, but I'm happy to cover that in a future talk. So that's all I've got for you now. Feel free to connect with me. Lori should have my contact information. Feel free to reach out to me directly. And guys, stay safe out there. Remember your vitals. Bonus points if someone writes in what's wrong with these vitals here. All right. Stay safe out there, guys. MD4 out.